All right, I think we're going to get started if everyone would take their seats. I wanted to welcome everyone to the Washington State Telehealth Collaborative. For those of you who are able to brave the freeways in the rain, thank you for making the effort to come down here. For those of you who are on the phone or on video, you were smart to stay home. The roads were pretty nasty today. I think what we're going to start with is just taking attendance. We'll start with the room here in Olympia. John Scott, University of Washington, Chair of the Collaborative, and Nicole, you want to say hi? So to my right is Nicole Lagrone, who will be taking minutes. And Ray, you want to say hi?
Ray Hamley from Woodward Industries.
Great. And I don't think we have any other members here in person, but I see quite a number on video or on phone. So maybe we can start with Chris Cable.
Yeah, hi, good morning. This is Chris Cable. I'm here.
Okay, great. And Chris, if you have video, would you mind turning that on?
I'm in my office. I don't have a video camera here, unfortunately.
Okay. All right. And then I saw Jeff Jones. Jeff, do you want to say hi?
Hi, Jeff Jones, family physician, Newport, Washington.
Great. Thanks for joining. So then anyone else who's a formal member of the collaborative want to say hi? I'm sorry, I only see phone numbers.
This is Cody Gillenwater with Medical Director with Regents Blue Shield.
Hi, good morning, Joelle Pati from University of Washington.
Good morning, this is Kathleen Damon with the Providence St. Joseph's Health Clinical Program Manager for Telehealth.
Good morning, this is Josh Frank, American College of Emergency Physicians at Confluence Health in Wenatchee.
Josh, thanks for joining.
Chad Gabeline from Virginia Mason.
Sorry, was that Chad from
Yes.
Virginia Mason?
Chad Gabeline from Virginia Mason.
Okay, great. Chad. And Chad, did you have anyone else from Virginia Mason?
I don't, unfortunately. There's a lot of there's a high volume of patients right now in the Seattle area, so we're contending with that at the moment.
Okay, I understand. Let's see.
Hi, good morning, Stephanie Cowan, Multicare.
Hi, Stephanie. Thanks for joining.
Lori Wakashige, Legacy Health.
Hi, Lori. Thanks for joining. So I'm just going to call out some names. Just make sure we didn't miss you. Let's see. Dr. Guff, Francis Guff from Molina. Are you there, Francis? Sheila Green-Shook. Cheryl Huchala. Okay. Dr. Jimenez, Ricardo Jimenez. Catherine Kie. Scott Kennedy. I know Danny Lorden couldn't make it. And do we have anyone from Seattle Children's? Possibly Dr. Lowe. Okay. Adam Romney. And then I think Cara Tal could not make it either, but Cara, were you able to call in? Okay, great. So just want to remind folks, if you're not speaking, please mute. And just a reminder of the agenda that you can see there. We have quite a number of items we want to get through today, and we do ask that if you're a member of the public and not a formal voting member of the collaborative, that you hold your comments or questions until 11:45 or the end of our meeting. We may get through things more rapidly than we thought. With that, what we would like to do next is to review the minutes from November of 2019. You should have those in your email, and we'll pull them up here. Ask folks to review those, and when you have time, if you could, if we could get a motion for approval in a second. Just a reminder, we did talk about some of the payment parity issues, which we'll take up again today. We talked about the nursing compact, and again, we're going to hopefully wrap that up today. And then we had a presentation by Dr. Ryan Sterling on some health economic outcomes of virtual urgent care. And then got an update from Caratel about the NRTRC. And just a reminder that the NRTRC meeting will be in April in Portland this year. And just another plug for that great conference, which is usually around $200 to register for that. Is a very good introduction to telehealth. So for folks who are interested, and we'll see if we can scroll down. And then Nicole and I went over some of the survey results and goals of the collaborative. We'll be coming back to. So is there a motion to approve the minutes?
So moved.
Sorry, who was that? Who said that?
This is Josh.
Thanks,
So
Josh.
move to approve the minutes.
Have a second?
Stephanie, I second.
Thank you. Discussion? Any amendments? Okay, all those in favor, please say aye.
Aye.
Okay, all those in favor say nay. Okay, great. Well, the minutes are unanimously approved, and we'll have those uploaded to the website. So next, we wanted to go to a final vote on the nurse. We could approve the nurse licensure compact. So just a reminder that these compacts are agreements between states, and you cannot change the language. And what this would allow is for nurses in the state of Washington to more easily get licensed in other states who've signed on to that, and vice versa. So I think there are approximately 15 or 20 states? 34. 34, okay. So we're a little bit late to this game, getting signed up to the nursing compact. We have approved a similar bill for the physician and the physician assistance compact a couple of years ago, and that is was enacted in law. So language, can add Nicole or? Okay. Okay. All right. Well, I know we've talked about it at least 2 or 3 times. So maybe what I'll do is see if there's any additional questions or concerns about the compact. And then if there are not, then we'll go to a formal vote to approve or not approve that. So I'm just going to open it up. Maybe, Joelle, I don't know, as a nurse, if you have any strong opinions on the compact.
Nothing's really changed since our last meeting. Thank you. I do have a question. What is the overall purpose of voting on this? What kind of weight is coming out of our collaborative in regards to a decision on this?
Well, it's a great question, Joelle, and I think that any kind of proposed legislation with a collaborative has kind of taken a deep dive into it and has had a formal vote, which there's, a strong opinion for it. It does carry some weight. It's non-binding, obviously. Maybe Senator Becker, and maybe you can speak to that. The question was, what is the impact of us, approving the nursing compact?
Oh, well, I can tell you when we go into committee and we hear a bill and we can say this was a vote from the collaborative. It was discussed. Pros and cons, we've thrown out ideas, et cetera, and then the entire collaborative has supported it by vote. That means a lot because the collaborative is very well respected for what they've been doing. So anytime we have a vote to back up something, it's the best move forward.
Senator Becker, do you have any concerns about the nursing compact?
The first compact bill that came was for the physicians, and it had to be all or nothing, and we could make no changes to it. And I had concerns with that kind of language, but the nursing compact has been worked out over a period of time, and so I'm actually comfortable with the nursing compact and would vote for it at this point.
Okay. And I know, as speaking as a physician, and now 2-3 years in, that it's allowed us to have much faster credentialing. So for example, we have a telestroke program in Idaho, and that has allowed our physicians to get licensed around a month, maybe 6 weeks, instead of 6 months. I haven't heard of any disciplinary concerns or anything like that. I think that there's one complaint I heard from my colleagues was getting fingerprinted, and that's not always necessary in every single state, but there are enough states now that do get fingerprinting to check for any kind of criminal history that every state kind of has instituted it. And it's just a little bit of hassle. Go down to the Washington State Patrol and get it fingerprinted, but that's the only complaint I've really heard from my colleagues. So other questions or comments about the compact? I know that Representative Riccelli couldn't make it, but he in the past has said how, as a representative in the Spokane area, that he has a number of military families that were moving around a lot, and also being on the border with Idaho. There are some families that live in Idaho but actually work in Washington, that he's strongly in favor of this bill and would like to see it.
And we had a discussion, Representative Riccelli and I, about the same thing, and we both are in agreement.
Great. Questions or comments? All right, well then maybe if we can go to a vote. So for all those who are in favor of endorsing the nursing license compact, say aye.
Aye.
Aye. Opposed, please say nay. Okay, so we'll take that was unanimous. Was there anyone who abstained? Okay, great. So we'll take that as the full attendee list approve this. So the next thing we would like to do on our agenda is move on to a policy update. There are several bills that have been introduced to both the House and the Senate, and we'll turn it over to Senator Becker and Stafford to talk about some of those bills. Maybe we'll start with Senator Becker.
Thank you. And Stafford, I left my notes in there. It has been a crazy week and a half. I have to tell you, yesterday I finally ate dinner last night, leftovers from my husband's dinner. So that's okay, I'm losing weight, but I have to say I sat right here yesterday and we had a news forum, and the very first thing I did is that I said, I have to tell you, I am so excited. 5389 mental health in schools, our via telemedicine bill passed off the floor 49-0. And so I am most excited that that's happened here. Chris Reichdahl with the OSPI, Superintendent of Public Instruction, is 100% behind it and advocating for it. I met with the governor, and now that I was in with the governor's office right now going through it, and they are 100% behind the bill. I think Representative Cody is behind the bill, and others. So we have a lot of force moving it forward in the House. I've asked that it go to healthcare versus education, because the aspect of education we've already been able to achieve in the pilot program. So I am most excited. I'm realistic. We have to put a couple stopgaps in that bill when we get it over there and make sure that it's set up to be successful. But that bill I'm excited about. The telemedicine training bill that we passed last year as a voluntary bill is now mandatory. We excluded the MDs and DOs as they receive well, it's in my bill, it would be mandatory. The MDs and DOs receive it in their, that training in the residency program. I'm on the board and asked that as and so we excluded them. However, I know there are doctors and DOs out there that have not had that training, and so I'm hoping Sean of WSMA reaches out to those folks and encourages them to get that training. It ties into not just the mental health in schools bill, but mental health in the overall picture. There's another one of my bills I talked about, and these are all things from here, is the telemedicine payment parity, and I see we have a discussion on that. And have a striker that just clarified some of the language, but we pulled it from rules yesterday, and so hopefully that comes out on the floor. And then that we had to change the dates to make the dates correct, et cetera. So once that gets out of here, then we can have a further discussion with Representative Cody on how we might incorporate some of what you're going to talk about later.
Great.
Stephanie, there are some other telemedicine training bills other than, or not training, other telemedicine bills that are coming out of both the Senate and the House that will address school-based kind of telemedicine in general. So I think we should watch and make sure that they actually are at collaborative's goal of what is telemedicine, where can we provide the services. I just make sure whatever we do that we keep that level of care getting better and better and better and better, and not just trying to get bodies in there to do it.
Say that you've been tracking or.
No, Senator Becker's saying anyway, there is one other bill from Senator Cleveland that would have, require the Department of Health to do a grant program, have school-based, centers, and it's a grant program to get telemedicine in schools.
And I think that Representative Riccelli has introduced the parity bill in the House. I saw that dropped on Tuesday. So do you know if the bill for the nursing compact, has that dropped as well?
That I do.
Has
it? Okay, yes.
It has. Okay. All right. So quite a number. Sounds like 5 or 6.
It's interesting because since we started the telemedicine thing, it seems like everybody's kind of starting to get on board, recognizing it's the wave of the future. So.
Okay. Well, so that's great. I'm just wondering if there's any comments on any of those bills or questions about any of the bills from members of the collaborative.
Hi, Dr. Scott. This is Lori.
Hi, Lori.
I did have a question about the training bill. So it did say that if you're a physician, you do not have to go through the training in that little box on the screen. Is that correct?
That's correct. And Washington State Medical Association wanted it to remain voluntary, and they justified it with the fact that those doctors are getting the training through their residency programs. But Sean Graham, who represents them, has guaranteed me that they will reach out to all of the doctors that took their training, their residency training before this type of training was available, and encourage them to do that.
Okay, so if our doctors did not receive it in residency, then we should implement what we had talked about before. Is that right?
And remember, in the collaborative, we have the training available. And so it's already available. And if you're with a group, a larger group, say, for example, Providence, that has their own telemedicine training program, you don't need to develop a whole new one. It would be available. If it were me, as the retired administrator, I'd say I'm going to utilize the one that's already set up, not have to set up another program. That would ensure that everything is complete. But it's as a small provider group, you can develop your training as long as it meets the standard, and we've clarified that in the striker on the bill. Or you can utilize the collaborative training that's already available.
Yeah, so just recall that there are 2 versions of the training. There's a free version if you just kind of want to brush up. But there's also a certificate program that was $25, and it's hosted on the Washington State Nursing Association website. Joelle was with us in helping us to get that set up. I think it takes about half an hour to kind of go through the slides. So as someone who does a lot of trainings, it's not that onerous. We feel like it's a pretty fast changing field, and it's good to keep people apprised on what's going on.
And I've talked to physical therapists, I've talked to the hospitals, I've talked to the physician assistants. They had some concerns. That's why we made the language a little clearer for them. But once they understood it was really a malpractice issue, and looking at what constitutes a visit, how do you document it, how do you code it, et cetera, that, you know, and more that's in the training, then they were comfortable with it. And I also told them that it would be much cheaper for them to do that than be faced with a lawsuit. So, from a patient, because they didn't, you know, have the knowledge.
Okay, great. Yeah, we've supplemented our training materials that we have standard here with those training materials, so thank you.
Other questions or comments?
Can I just add one more note?
Yeah.
One of the recommendations that kind of came up recently is to expand those who can treat the students in the schools. And Senator Becker did an amendment that was adopted yesterday, was passed unanimously, to add psychologists in addition to psychiatrists who can treat students in the schools.
Thanks, Dr. Quite a number of things to consider and digest. Other comments on these bills or feedback? Gonna chat here. Okay, sorry, it's a technical comment. All right, well, hearing no other questions or comments, maybe we'll move on to the next agenda item. And that's to talk about a bill that we haven't talked about. It came up at the last legislative session in 2019. That's Senate Bill 5759. It pertains to remote technology for eye exams. And so I just wanted to preface this with a comment that we're going to be splitting up this discussion over two of the collaborative meetings. We couldn't get everyone to come today, including Dr. Ruslan Gelder, the chair of ophthalmology at the University of Washington, and then folks from the American Optometrists Association. We do have representatives from them in attendance, and certainly welcome their questions during the public comment period. But we wanted to welcome Nick Shalago, not doctor, but Director of Government Affairs at 1-800-CONTACTS, to explain a little bit about the technology they offer and how this might impact 5759 adoption. So Nick, we'll turn it over to you, and we're happy to advance the slides just whenever you're ready. But say next slide. Yeah. Great.
Wherever you'd like.
Okay. How about here, so I can?
Sure. No, thank you.
Thank you first, Dr. Scott and members of the collaborative for accepting our request to review this bill along with other policy alternatives that we've worked out in other states. And certainly Senator Becker for
I think it's been a lot.
That's great. For coming up with the idea of bringing this idea and these policy alternatives to the collaborative for review and for potential recommendation. As Dr. Scott said, I'm Nick Shalago. I'm with 1-800-CONTACTS. I'm here representing our nearly 60,000 customers that we have in the state of Washington. I just want to be clear from the onset, this presentation is an example of one of the platforms out there. So it's our platform, Express Exam. I don't speak for other companies that are in the marketplace, but I will say that they're all somewhat similar to what we're doing. Also, I know there are a few people in the room here that they have questions or on Zoom. Happy to stop at any point to go through those. Next slide. So this is just an example of the 38 states, the states where we're currently operating. It doesn't represent all the states where we're able to operate. 38 states allow for online vision testing services with some varying degree of regulation from what we do here, which is under the general telemedicine statute, to some limitations on the length of time between when individuals can use services and other things. Only 4 states currently ban the use of this technology: South Carolina, Georgia, Indiana, and New Mexico. Next slide, please. Thank you. So, like I mentioned, almost all similar systems in the marketplace aren't doing refractive technology at this point. They're simply doing a vision acuity test. And this is the case in Washington State, where systems that we have in place capture clinical data, whether that's a questionnaire, which I'll walk through, or images and other information. And then that's forwarded to an ophthalmologist, board certified in ophthalmology, licensed, in this case, in the state of Washington. They review that information. And next slide, please. So they review that information, and they determine a couple things. One is this tool a good fit for this individual patient? And then secondly, if that's the case, if the data captured validates that the patient's existing prescription can be renewed for another year or two.
So Nick, can I just stop you right there?
Sure.
So this is not for the initial prescription, this is just for renewal.
Correct.
So I've already had my baseline full eye exam, dilated, look in the back of my eye and all that.
Absolutely.
Okay.
So and I'll get into that in a minute, actually. Next slide, please. So the questions that we ask and the parameters that we use to determine patient eligibility are developed by our physician panel, which is made up of leading experts in ocular health. And they take into account the clinical guidance and medical evidence put out by the American Academy of Ophthalmology when they make those decisions. And so this is an example of a few of the physicians that we have working with us from Vanderbilt, Stanford, University of Cincinnati, that have come together to help us design the system and then determine patient eligibility so that we can guarantee that it's being used safely and effectively. So getting to Dr. Scott's point, there's a couple things that we want to put out there right from the beginning. First, to say that this is not a comprehensive exam. This is not a replacement for a comprehensive exam. So in order to use our service, you have to have an existing prescription for contact lenses. For contact lenses, it has to be based on an in-person exam, comprehensive exam. They've done the fitting. In most cases, they've worn those same contact lenses for at least a year, and now they're coming back to get a prescription renewed. I would say that there aren't any legitimate companies out there that are selling this as a replacement for a comprehensive exam, or are not being upfront and honest with consumers as soon as they start the system that this is not a comprehensive exam. So this is what you'll see on our system. These are screenshots of the actual platform as you go through the system. Yeah. So you recognize that that box is not checked when you get in there, so you can't just go through it. You have to check the box to show that you understand that this is not a comprehensive eye exam. It's simply being used to renew contact lens prescriptions. In our case, other companies are using it for contact lenses and or eyeglasses.
May I ask you a question? So when I wore contacts, the only way I could get them the renewal was to have another exam.
Correct.
So, and that was face to face, obviously. So you're saying upon that renewal that you would have a telemedicine type of exam?
Correct.
So it keeps you from coming in down here.
I understand, but the one thing is then they test for macular degeneration, et cetera. Are you capable of doing that?
We are not doing that, and we're educating patients that if that's what you're looking for, if you're looking for a comprehensive exam,
so
this is not the tool for you.
Okay.
And I'll get into the parameters of who we allow to use it and what intervals based on the medical evidence.
It's like how many times you allow people to renew this way. So I think you'll get to that.
Yeah. So we use the location services embedded within your phone or your computer or tablet to make sure, to determine or to understand where the patient is at the time when they're taking the exam. For a couple of reasons. One is we want to make sure that they're in a state that allows them to do that, so that we're not that we're in compliance with state laws and regulations. And then the other is we want to make sure that the clinical data that's captured and sent to the physician, that physician's licensed in the state where the patient is at the time that they're taking the exam. As you guys know all too well, telemedicine's been happening in Washington State for several years under, as I mentioned, the general telemedicine law that was passed. Vision testing services have been operating in this state for 3 years, 3 to 4 years, depending on the company. We've been working either with another company or with our own Service Express exam over the last 3 years. So we do that under the existing laws. And the important part to remember is, just like all forms of telemedicine, there is a mechanism for regulating the use of that and the physicians that are using that, and a disciplinary authority that governs that, which is the Washington Medical Commission. So all of our physicians that we use, as I mentioned, have licenses here in Washington State. They're under the disciplinary and regulatory authority of the Medical Commission. Once you check the box that you recognize this isn't a comprehensive exam, then you enter the portal, and you're asked a series of medical questions. And this, I think, gets to your point a little bit, Senator Becker. One is, there are individuals that qualify or eligible for the service, and there are individuals that are not. Some of the things right off the bat that would disqualify you is if you're under 18 or you're over 55. So you have to be within that age range in order to use the service.
Why is that, Nick?
And that is because the American Academy of Ophthalmology puts out guidance on the frequency of a comprehensive exam. So if you're not between 18 and 55, you probably do need to see somebody every year or two, and this isn't a good tool for you. You have to have an existing prescription, as I mentioned, generated by an in-person exam, and that includes the fitting and all of the other components to a comprehensive exam. And then you have to have seen somebody in person for a comprehensive exam within the last 4 years. So again, that's because the medical guidance put out by AAO says that this is not a tool, in their opinion, and medical guidance points, this is not a tool that should be used forever. It can be used for a certain patient population, but also not forever. So you should be getting a comprehensive exam every 4 years if you're within that age range. And so we require you to do that as well. Even in states where we're not required to do that, this is a state where we're not required under any law or regulation to force somebody back into the office every 4 years, but we do so because we think it's good for patients, but also because our physician panel has set up that parameter, and those individuals are recommending good science, and no one that's licensed has a medical license is jeopardizing that license by providing bad care through a system like this, I think.
Nick, another question about the continuity of care. If I say I have a contact lens prescription from Dr. Van Gelder, but I use the service, is there a note that goes to Dr. Van Gelder, and he at least knows his renewal? Because, I mean, sometimes there's a prior relationship, and there might be something unique about my contact prescription that he'll say, oh, no, I need to see John about. Is there, because we've seen this in regular telemedicine, that maybe you're a national telemedicine company and you don't know everything about me. It's only what I tell you, but if you don't have access to the charts, it's not that communication, there's a potential for disruption of continuity care and maybe some unique things that you just don't know about.
Yeah, no, I mean, we understand that concern. At this time, there is no communication with the original prescriber or the individual eye care home. What I will say is that if there's an issue with a very specific type of, they use a very specific type of lens, or something that can be picked up by an ophthalmologist because of the type of lens that they use, all that information is still captured and sent over to the reviewing ophthalmologist. So not only do you have to have the prescription, but you enter all the parameters of your prescription or take a picture of your prescription, which is part of the data that's sent over.
So did I misunderstand you then earlier? Because I thought that you sent to their primary eye doctor the results of the exam.
No, we send all of this information to one of our physicians. The physician who works for us that's licensed here in Washington to review this information, not necessarily their optometrist or ophthalmologist. Of course, the patient has access to all this information, so if they felt that that was important, they could take that information and send it over to make sure that their medical chart remains updated in the time between seeing that person in their office.
I have a question about the physicians. Are they employed by 1-800-CONTACT, or are you using a third-party
Yeah, so they're not employed by 1-800-CONTACT. They have no financial incentive to approve or disapprove. They get paid the same whether they accept and approve or not. They're paid by scan in the same way that most arrangements are set.
Like a contract.
Not an insurance benefit.
So it is not an insurance benefit because, for the most part, we don't really charge for the service. This service is provided almost always free or by us. There are companies out there that charge. If we are charging, they're generally coupon codes that we have that would bring that down significantly. But in comparison, an online vision test is about, let's say, $0 to $40. Comprehensive eye exam is $187 nationally on average. And so you get to a point where most of the people that are using this, it doesn't even get to the insurance level because we're not.
Nick, I just want to, I've never done these, or, you know, is it basically you're looking at a visual cue like a Snellen and you know, A, E, O, that.
Okay, so, yeah.
Yeah, and what's to prevent people from gaming it, like having their 16-year-old who has really good vision?
This is all I'll get into.
Okay.
Yep, and I'll show you.
And I can just,
Because
I
we
mean,
have those
people do crazy things. I'm just like,
So,
and this, I mean, another thing, Nick, is that I'm an infectious disease doctor. Is I've seen people who leave their contacts in too long and they get like really bad infections. Like, is there education on how contact lens care and all that kind of stuff?
Sure.
Okay.
I'll get into that.
Okay. Sorry.
No problem.
Very interesting.
So as we move through the system, so you get through the first part to determine your eligibility based on existing prescription, age, et cetera. Then we get into the medical history questionnaire and ask several questions related to your eye health and your health generally. So some other things that would disqualify you from being able to use the services, you know, you've ever had eye surgery, you've had pre-existing conditions such as diabetes, glaucoma, cataract. Any one of these things would screen you out of the system, and you would not be able to proceed further. And as I mentioned, even in states where we're not required specifically to ask any of these questions, we already do because we want to promote good eye health. We want to make sure that people are using these tools appropriately. And just to point on that, these things aren't, you know, weighted where they stack up to the point where you get kicked out of the system. If you answer any one of these questions in a way that would disqualify you, you're immediately stopped, and you get a note that says, "I'm sorry, this tool doesn't work for you. You don't qualify or are not eligible for this." We recommend that you go in and see somebody in person for a comprehensive exam. And here's a list of 5 people in your area that we would recommend that you go see.
So I'm still wondering, if I have a prescription, why I need to go through you?
So your prescription has a finite period of time on it, right? So it expires. So when your prescription is expired, we can't sell you contact lenses. You can't go to Walmart or Costco and buy contact lenses with an expired prescription in the same way that you can't go get a medication refilled if it's expired. And so you have to go back in to do a vision test to determine that they can renew or write you a new prescription if you need changes to it.
Nick, just a question. What % of the time do people actually check a box here?
I don't have the answer on checking a specific box here, but I can tell you that about 30% of the people that start the process do not get past this, whether it's checking one of those boxes, over 55, can't provide prescription information, or haven't seen someone in person.
And they haven't paid anything, so, you know, just
correct. And even at times where we do charge, if you don't make it through the system, we do not charge you. If you don't get our company does not charge you for using the service.
Okay.
And I know that this is specific to 1-800-CONTACT. Can you give us a sense of how many other people are, you know, creating tools like this, and if they have similar protocols?
So I know of, off the top of my head, I know of 3 other companies that are currently operating in the marketplace.
Okay.
All of those companies we work with, they're competitors of ours, but we work with in situations like this. And they all use the same protocols and standards that we use. variation, but for the most part.
And are people,
And that variation is based on what their team of physicians says is appropriate use.
I remember that Warby Parker, which is the online classes place, that they have something like this, and they somehow, they got shut down. Is there a kind of analogous,
So so they're still using their system. There was a company that was shut down. I'll be very clear, they were not shut down because of, from my understanding, because the FDA found that they were doing anything wrong, other than marketing it without pre-market approval. So there was no bad outcome, or they didn't have the information put together. They were also doing refraction, which is a little bit different than the acuity test that we're doing. And so the information that they got from the FDA was that if you're doing a refraction, also, this is my understanding, I'm not speaking on behalf of that company or the FDA. My understanding is the information that they received was if you're doing a refraction, that is a different level of approval than just registration with the FDA, and they would need to present information for that approval, and they didn't get to that point. So if you go through and you make it through the first part of the test, which is the medical questionnaire, then you move on to the actual vision test. So a couple things that we check for and capture information on that's forwarded to the physician is making sure that you have no irritation of the eye or anything that stands out in the picture of the eye. So if you move on to the next screen, you'll see that we capture photos of the individual's eyes, looking up, down, left, right, so that if the physician sees something that indicates that something's going on or concerns them, similarly to not passing the first part of the exam, you get kicked out of that system. And you get the note about going to someone for person. So then we go on to the Snellen chart, which Dr. Scott mentioned. And this is how the individual actually walks through an acuity test to determine if they can still see using the contact lenses. So a couple things that Dr. Scott brought up and a couple things I'll mention. One is we're one company within the marketplace that does contact lenses that requires you to have the contact lenses that you have in when you're taking the exam. So the company that I mentioned before, because they were doing a refraction, they didn't want you to have the contact lenses in because they were trying to match and see what your prescription was. We're just simply testing to make sure that the contact lens prescription that you currently have is still working for you. Dr. Scott brought up a couple of things. So the camera on your phone can actually test approximately how far you are away from the camera, from the equipment. So from that, they can determine that you're the right distance away from the phone. But we also video and audio record this entire interaction so that you don't have your 16-year-old behind you saying, say N or hit N, K, because we've seen that. And so all of that is captured again and forwarded to the ophthalmologist. The ophthalmologist is reviewing that, similarly to you not being able to pass the exam simply, or you having something, your eyes really red, and they're like, yeah, maybe this isn't cool for you. If they hear you being coached through the process.
Can I ask you a question?
Yep.
So these are our cell phones, and it's an app on our cell phone.
Yes, in this scenario, this is an app on the cell phone. We have an app and we also have a web-based tool.
So the question that I have is, does the federal government have to do any kind of an approval of your equipment, like in the?
FDA.
Yeah, so the FDA doesn't, and I'll get into that when we talk about the actual legislation, because in our discussions with the FDA, unlike that other company that found out that they have to have approval because they're doing refraction, in our discussions with the FDA, based on clearance from the Snellen chart from years ago, we just need to register our product with the FDA, and then they need to know that it's out there, but there's no approval process that they actually have in place for equipment like this at this time.
Are there certain versions of smartphones it doesn't work on? Like, say, if I have an iPhone 4, or which?
Yeah, and so you'll have to have you're right, the operating system and the equipment has to be that with which we can operate. So if you have an iPhone 4, this isn't gonna, you're not even gonna be able to download.
Obviously, you need a smartphone.
Right, but again, I'm talking about our technology. I don't know what others do, but.
So web-based tool, is that, I'm assuming that means that it's the actual physical computer, like a laptop or a desktop,
Yep.
so you would need to have a camera.
You have to have a camera.
Okay.
Yeah, same kind of technical equipment that you would have on your phone.
Oh, so it can be either a laptop or a smartphone?
Yeah,
Correct.
or like a plug-in camera.
Or a tablet? Oh,
Have
okay.
you had any issues with like variation with different types of cameras that are used?
Not that I'm aware of.
Oh, okay.
So once please. So once you complete that entire process, as I mentioned, all that data is then forwarded to an ophthalmologist, board certified in eye care, licensed in the state where you are, who can then review all of that.
Can I choose?
I'm sorry?
What if I don't like Edward Chow? Can I choose Dr. Chang?
You cannot.
Oh.
Yep. So, that individual will review all of that data and then determine if they can renew your prescription using their independent medical judgment and their knowledge in the area. They don't make any changes to, as I mentioned, to the prescription. So if you had AccuView Oasis, this power, this size, and you can't pass the test with that, they don't renew your prescription. They don't try to make changes to your prescription. You get the same note that says, I'm sorry, this tool doesn't work for you. Here's a list of 5 optometrists in your area. We highly recommend that you go in and see somebody for an in-person exam. It seems like maybe something's going on that this tool isn't going to be able to provide you the service that you want. So we have actually worked with legislators and regulators in multiple states to educate on the services, kind of like we're doing here. We've done in the Health Committee here in the Senate, looking at things that things that work and things that don't work in terms of providing consumer access to these services, but also prioritizing patient safety and making sure that that is put at the forefront in any bill or regulation that's put out. So we've worked in states like Virginia and Minnesota last year with not only ophthalmology and industry, but optometry to come together on legislation that everyone felt provided adequate protections for patients, knowing that the medical board is always there to step in to fill in the gaps, but also to provide consumers with the access that they want and need. So all of these bills provide options for patients. You can have an in-person exam if you want. You don't have to use any of these tools out there. They exist if you'd like to. There are tools out there that allow for face-to-face interactive two-way, but a tool like ours, that if you want to be able to do store and forward technology and do a simple vision acuity test to get your prescription renewed, that's out there as well.
Can you say a little bit more about access? Have you put any numbers on access? Like, what % of people, is it difficult for them to get into optometrists? I am a contact lens wearer myself, so when my refill comes up, it's often 2 months out to get an appointment, and literally they're 1 block away from where I work. And I have to dilate my eyes, so like half my day at work is kaput. So I mean, I can understand how this can help someone like me, but I'm thinking more rural areas of the state where maybe the nearest optometrist is 40 minutes away.
And even though it was over an hour.
Yeah.
So
do you have any data on quantifying that access issue?
So it might be a little off, but if I remember correctly, the last workforce study that came out from the AAO showed that 26% of counties throughout the United States were underserved or had no access to an ophthalmologist or optometrist. Access can mean a lot of things, right? Yeah. Can't be able to get in. You don't have someone to go see. It could also mean that you can't afford to go see someone for a number of reasons. Maybe you don't have the insurance. Eye care insurance is not like health insurance. It's something that people have to pay out of pocket for in most cases. And then, so cost can be an access issue, but also time. If you work at a job where you have to take off to go get that 1 o'clock appointment on a Tuesday, that can prevent you from going in to see somebody, but it could also cost you in terms of real dollars that you might not want to do it. So this provides a 24/7, 365 access to that kind of tool where individuals that qualify can go in and see somebody and get their contact lens.
But again, this is only renewal.
Only renewal,
Okay.
and only a maximum of 4 times. And so, right, at some point, you're going to have to go in to see somebody because that's just good eye care. We recognize that. What we're trying to do is provide access to a tool in the interim that you don't have to do that. It saves costs, it saves time, and it creates access. To Dr. Scott's point from earlier about the unhealthy use of contact lenses, a tool like this can provide an opportunity for individuals that are at the end of their prescription that might use their contact lenses in a way that they aren't designed to be used, right? So they turn a daily into a monthly or a weekly, or they turn a monthly contact lens into a 2-month, 3-month because either they can't get in to see somebody or they don't want to pay to have a comprehensive exam. So it goes both ways. There's certainly an opportunity for people to misuse their contact lenses in multiple ways. We've seen and heard all the stories about people, washing their contact lenses in a river when camping and then putting them in their eyes. But we think this tool provides we think this tool provides an opportunity for people that want to use their contact lenses in the way that they're designed, but can't get in to see somebody, to renew it so they can use those in a way that they are.
Nick, we hear a lot about the cost of healthcare. Do you feel like this is something that could save the healthcare system money, or is it a net negative, net neutral?
I mean, I think it certainly can, especially if there are companies like ours that are not charging. So in the long run, in the grand scheme of things, I'm sure that it could. We haven't put or fault, any dollar amount on that yet. I mean, I think if you look at, the entirety of healthcare, something that's been in the marketplace for 3 to 4 years is probably still in its infancy, and the technology continues to only get better. So as that happens, and as laws and regulations allow for that innovation, I can certainly see a time when this could be a game changer for people to get the eye care that they need.
And I have another question for you. So I'm going to lose it now. You say that it's no cost to the people, but sometimes you charge. What would cause you to charge, and what would that charge be?
Yeah, we've been doing this for 18 months under our own brand, so we're still trying to figure out, from a cost perspective, what is the right number for patients. So I don't know the answer to that in terms of when and how we charge. That's more of a marketing.
How do you guys make money?
Thing. We make money because when you get your prescription, more than likely you'll buy from us. So under federal law, we have to give you your prescription just the same as you would in the optometrist's office or your office. You write a prescription. You get that, and you can take that to your optometrist's office, Costco, Walmart, wherever, CVS. We think that because we've provided this customer service to you, customers will buy from us again.
And this is in the Stark or anti-kickback issue?
Yeah.
I mean, I know that I cannot offer a free telemedicine service if there's any kind of downstream revenue. Like, I can't offer a consultation with our cardiothoracic surgeon if there's any kind of inducement for them to come and get a heart transplant.
Right.
So
because you're under insurance contracts?
No.
No, this is Stark.
This is Stark.
Stark Amendment.
Yeah.
I understand, but that's,
It's an inducement. Yeah.
You have to offer fair market value.
Refer for
Yeah.
the purpose of making money.
yeah. We haven't had that issue.
Question then is, for other,
In
companies
terms of
for contacts.
contact lenses. So we'll be the first to tell you we are not the cheapest contact lens seller in the marketplace. If you want to find cheaper lenses, you can find them elsewhere. We provide excellent customer service, and this is an extension of that customer service. So we're helping people continue to renew and get easy access to that. And so that's,
That's fair.
Yeah.
Nick, I'm going to put a pause here, and sorry, I feel like I've been dominating a lot of questions. I'm super interested in this, but I want to see if there's anyone online who has a question for Nick. I'm thinking in particularly Josh, since you're ER doc, you probably see some eye issues, probably some people who have contact lens issues. Any questions from the group right now?
I did have a couple questions. Thank you. So when you went through how they can just be disqualified by marking something in their history or their age, I was wondering, once they mark themselves as disqualified, is there anything to stop them from going through again and trying to qualify?
Yeah,
I don't know the answer, like if you can sign out and then sign back in.
Yeah.
I don't know the answer to that. I can get you guys the answer to that question. But in the same way that, you know, to be honest, if they're disqualified from us, I guess they could go to another vendor and try and do it the same, but it's really not in their best interest to do that. But also in the same way that a patient can come into you in your office and not give you accurate information to try and get something that they want, it's no different than that.
Yeah, you can look
Sure.
what to say to get antibiotics for you, you know, or to get appendicitis. So people unfortunately do that all the time. Josh, you have some other
Sure,
questions?
and well, no, I mean, that was the main perspective. In the ER, we know people game the system. We try to keep them from gaming the system in ways that are harmful to them. So, you know, the big picture question is, how are you designing it? So, of course, patient responsibility has to be a factor, but what safety measures do you have in so people don't have an easy way to make a very bad choice for themselves? That's the main question there. And then I had another question regarding, you said that if they do need an eye exam from an eye doctor or an optometrist, that they're referred to, you know, a list. How do you make that list?
Yep. So if I can just address your first question, I think we've done our best to establish safety protocols and parameters around eligibility to make sure that it's not easy for patients to use this when it's not in their best interest. We are the largest seller of contact lenses in the world. Federal law requires us to validate and verify every single contact lens prescription that we sell. Because of that, we have a very massive database of all of the optometrists in the area. Using the location services on your phone, we know where you are when you take the exam, and we can provide you with the names and contact information of individuals in your area based on our verification process to point you in the direction of somebody that can give you a comprehensive exam from where you're at when you take the exam.
And you referred to ophthalmologists, why not an optometrist?
So we use ophthalmologists to do the screening.
Yeah.
When we refer out, we actually refer to both.
Okay.
It just depends on who's in your area.
Okay, cool.
So,
Okay, so it's geographically determined. That's the main question. Thanks.
yeah. Geographically determined, and then using our database to know who is actually in the area.
So it's not a specific agreement referral network.
We have no referral
general
agreements, there's no incentive for us to over one over the other. We just simply do it again as a customer service tool.
Are there other questions from the group? I have one, but I want to make sure everyone else has an opportunity to ask a question. Particularly anyone who wears contact lenses. Has anyone ever used this service?
No.
I'm due for renewal, so I'm very and I'm a little concerned because reading is really hard right now. So my question for you, Nick, is how is patient data handled, especially data privacy? I mean, I think are you guys bound by HIPAA and
yeah, so
high
if I can just get to these last two slides, I'll cover that in there.
Oh, yeah.
So, you know, in states like Virginia and Minnesota, as working with industry and ophthalmology and optometry, we've come to an agreement on what those safe standards are when using store and forward technology. So here's an example of some of the provisions that are in those bills that we have agreed work for patients. So making sure that they get an updated medical history at the time, making sure that they qualify and are eligible for the service. Same standard of care as an in-person exam, totally fine with that. Not renewing solely on the use of online questionnaire, making sure that the physician that's reviewing the patient data is is licensed in the same state, and then patient records, holding them to the same standards as if they were in the doctor's office. So we are bound by those same laws and are fine with that. And then if you can move to the next slide, just talk a little bit about some of the concerns that we have with 5759 and some of the things that we're fine with. And the HIPAA compliance gets into that. So there are agreeable provisions within 57, 59, being held to the same standard of care as somebody that's providing a vision acuity test in the patient in the office. Again, totally fine with that. Being regulated by the medical commission and having our physicians licensed under the state of Washington, totally fine with that. Our company, we're HIPAA compliant. We don't need to be because we don't accept insurance, but we remain that, we have HIPAA compliance. We would be totally fine with any law out there that requires us to have, to hold on to patient data under HIPAA. Some of the things that we can't agree to are what we would consider to be things that ban the use of the technology without actually saying that they ban the use of the technology, right? So stacking up some of these unattainable provisions on top of each other as they do, and as is written in the language of 57, 59. I mentioned there's no process that the FDA has for approving a service like ours. So if a bill in Washington State says that you can only have access to these services if the FDA approves it, we can't attain that. So there's no way for us to do it. Effectively bans the use of the technology in the state. I don't know how you.
Let me ask you a question then on that, because I don't remember what the language in the bill is, but could the bill then read FDA approval if FDA approval is required at some time in the future?
Yep.
So it's if that
If
happens.
applicable, something like that, sure, that would be fine. But at this time, as I mentioned, there's no process for that. So if this, let's say this bill passed last year or this year, without making any changes, you can't use the technology in the state.
Question 2 is unreasonable continuity of care requirements. What constitutes unreasonable in your mind?
So having to have an existing relationship with the patient's, with the consumer's eye care home, we would consider to be unattainable or unreasonable from our perspective.
But I'm going to push back on that because we do that all the time. It's kind of the standard care in telemedicine. You just ask them, who's your primary care provider? And that's really easy to get that in your database and the fax it to them. I'll just say I'm a little bit concerned by the disruption and having not good continuity of care. Technologically, I know it can be done. So I'm gonna push back on that one.
And that's fair. I mean, we're here to have the conversation and present our side of it, and there are alternative viewpoints. I would point out that in states where we've come to an agreement with medicine, optometry, those types of provisions haven't been included in there. Now, if the medical board, after the fact, makes that a requirement, then that's what the medical board does, and we would abide by all of those things. But making it prescriptive in state law is something that we feel is not necessary when there is another entity that includes experts. This is very unique to the state. We were talking about this earlier. That don't have experts from telemedicine and from healthcare looking at telemedicine issues, particularly from a policy standpoint. But most states do have a medical board that's made up of experts in providing care to patients. And so if they look at this and say, you know what, that is, while it wasn't included in the bill, it's reasonable for us in protecting the public to make that requirement. I think that's one thing, but putting it into law is something else, particularly if the general telemedicine law in the state does not require it. But you're only requiring it for one small portion of the healthcare system.
Fair enough.
I want to go back to performing the same level of evaluation as an in-person.
Yep.
So that would mean that you would have to have all of the equipment to do all of the things as a complete exam.
Yeah, so, and that's, make a very distinct point there. We want to be held to the same standard of care as doing a vision acuity test in the office. We are not doing a comprehensive exam. The patient recognizes that we're not doing that. We should not be held to the same standard of care as someone doing a comprehensive exam in the office, and we're fine with that. And then a couple other things. Performing that same evaluation as an in-person exam. I don't know if including a physical eye assessment, that's in the bill. I don't know how you do a physical eye assessment using an app. So again, that kind of legislation, that kind of language eliminates access to technology. I don't know how you provide a reasonable accommodation for a blind person under the ADA to do a vision test.
Well, it's not blind. It's what if they have really bad vision when they're 20/200 and they've got their contacts out. Yeah, and this has come up on other things on our own website and healthcare websites in general. And I think this is a gray area. So you're not going to be unique to this.
Yeah, but my point, or I guess our point on that is that this is not a tool for everybody. So if you have extreme vision issues, you should probably be going in to see, this isn't the tool for you. So, you know, and I'm happy to answer any additional questions. I think we've covered a lot of it, but based on the information that I provided, based on what we've done in other states, you know, we have extreme concerns with an approach similar to 5759. Appreciate your willingness to look at that and compare it to what we've been able to work out in other states. I would also point out, just in closing, that across the industry, in the 38 states that we've been operating in over the past 3 to 4 years, there's been over 1 billion vision tests done nationally. Not a single adverse event, not a single malpractice claim, not a single consumer-driven complaint to a medical board. I think that indicates the level to which we've gone to make sure that these are being used safely and effectively.
So last year, though, in testimony, we did have people testify that there were things that should have been caught that did not get caught before that.
Not using the exams. So they said, their point was.
I'm just trying to remember the testimony.
Yeah, their point was that there are things that could go missed by not doing a comprehensive exam, or individuals.
No, they pointed out.
Well.
And I don't know if it's.
Yeah, I don't recall that they pointed to this being the reason. There might be individuals that are not getting an exam or trying to do that. We are unaware of any adverse events, malpractice claims, or medical board. If individuals are, my guess is that if someone were to have a complication from using one of our services in the last 3 years, we would know about it by now. So we'd be the first to say, we're not going to catch everything because we're not doing all of that stuff. But people choose to take that on as personal responsibility, taking these vision tests as opposed to going in for a comprehensive exam every year. That's a choice that they've made.
Nick, there was a question that came in on the chat, and it goes back to payment. So who's paying the ophthalmologist to do these? If it's a free visit from a patient's perspective, is 1-800-CONTACTS paying them?
Correct.
Okay. All right. I'm not sure that this gets into like a state policy issue, but it does raise my hackles when we start talking about Stark laws and kickback. So just something to think about. The pricing needs to be fair market value. There are other questions on the chat, Nicole, or maybe we can have people chime in from Zoom land. Folks have questions for Nick? Comments? I mean, I can see the great value in this, and definitely as a time saver, active care, money saver.
Could we clarify where the how it's used and?
Yeah, there's I mean, you said that it's HIPAA compliant, but do you ever use that information to market to them?
So HIPAA doesn't allow us to do that.
Okay. So just to, in terms of procedures, we're going to put a little pause on this discussion. We'll obviously have time today for public comment, and we do have folks from Washington State Optometrists Association, and then they will be giving a formal presentation next time, as well as Dr. Van Gelder from the Department of Ophthalmology, is also the president of the Washington State Ophthalmologic Association. So we'll have a different perspective next time. But if it's okay.
What's the timeline on this bill? Do we know? Like, when do we?
Is there a bill that has been proposed again this
So
year?
the bill is still active. Okay. We've asked committee members to delay the action of this session while the collaborative looks at.
And I think that would be a reasonable ask and a reasonable ask for.
We have not received any word back from Senator Cleveland, but we agree with it.
Okay, great. Thank you very much, Nick.
Committee, there's hearing schedule on it.
Oh.
It was heard last year, so I don't,
But this
it was sent back to committee whenever because the bill's, that's where the bill is, right? It's not scheduled for exact order. Right. Thank you.
Thank you very much, Nick. Okay, so the next agenda item is kind of a follow-up of payment parity. And so just to refresh folks, what we've talked about before, payment parity is the concept that you get paid if you're doing a telemedicine visit the same as if you're offering that in person. So a lot of telemedicines are billed on time. So for example, a 15-minute appointment by telemedicine, usually a 99213. The parity language, I think, addresses that. What has come to our attention is this idea of a narrow network, and there was a bill in the state of California that passed that included payment parity, but also banned narrow networks. So what is a narrow network? A narrow network is when a health insurance company has contracted with a telemedicine provider to exclusively provide all telemedicine services through that organization. And Denny is not on the call, but he has encountered this in the Providence system where they've been denied telemedicine coverage for specialty services, and we've also encountered it at the University of Washington, saying that if you want to have any kind of telemedicine visit, you have to work with this national telehealth provider. We're concerned about that because we're offering pretty unique tertiary and quaternary specialty care, which there's no such provider in these national telemedicine networks, and also has disrupted continuity of care. These are patients we've already seen in person. They now live a long ways from the healthcare facility where they got their care, and rather than make them drive in, we want to do a telemedicine visit. So I just wanted to let folks know about the California bill and how they address this. So we're just going to walk through that. So the components of the bill are first that it does require payment parity for as if it was provided in person. There's coverage parity, and it specifically bans narrow networks. This is the actual language. It says that the bullet areas I'll draw your attention to, it goes into effect in about a year. The health insurer shall reimburse the treating or consulting healthcare provider for the diagnosis, consultation, or treatment on the same basis and to the same extent that the health insurer is responsible for reimbursement for the same service through in-person diagnosis, consultation, or treatment. And I think the current parity bill has very similar language, so not a whole lot of difference there. It does, however, extend parity to patient cost sharing, and we basically don't want patients to incur more costs because they're doing telemedicine. So it would not exceed the co-payment or co-insurance applicable. So that's something that California had added. There is rate negotiation. So this can be between the health system and health insurers, specifically if there is no in-person equivalent. And then the last component of the California bill was that it should not be limited to services delivered by a select third-party corporate telehealth provider. So the parity bill, and I don't think this is from last year, that was proposed and passed the Senate. We required payment parity for telemedicine. It does allow for negotiation, especially if you're over 11 or more. The reason for that is I think that the smaller entities just don't have quite the leverage, so that we're trying to make some protection there. Facility fees could be negotiated. It removes the store and forward, preliminary office visit, and includes directives for the collaborative to study it, I believe, Senator Becker. Anything more you wanted to?
Yeah, I do want to add, this bill would have actually probably made it out, but, the bill, we had it in the Senate, did not have a fiscal note, which we call a fiscal note, is telling how much it's going to cost to, for the OIC to administer the project. And there was a fiscal note added in the House of 2 point some FTEs in the OIC to look at this process. And I questioned why that was added, because to me it didn't seem like anything in this bill should generate any more work. But I had fiscal staff look at this, and the portion that says permits hospitals and other groups of 11 or more to negotiate different rates causes them to have to do a different review. And so it's a legitimate fiscal note according to our fiscal staff. And so when this bill goes over with the way we changed it to the groups of 11 or more, it will go to, it has the potential to go to what they call the approach committee over in there, or Ways and Means over here. The interesting part is that usually any monies that are charged to do the services that we're asking come out of the operating budget, but the OIC is solely funded by insurance carriers paying a 2% premium to do business here. And so I feel that it was inappropriate to send it there, and that's one thing that I'll fight.
Okay. All right, so maybe I'll open it up for discussion. Is this something that other providers have encountered? And I'll certainly want to welcome comments from Chris Cable at Kaiser and Cody Gillenwaters. Cody, I'm sorry I didn't take the opportunity to introduce you, so I'm going to do that now. So many of you guys remember Brody DeChinko, who represented Cambia Regents, and Brody has joined Amazon, and Cody is representing them, and so we welcome you, Cody. But let's open it up for discussion about maybe this idea of the neural networks and some of the things that are in the California bill.
Hey, John, this is Chris Cable, so I'll start. I guess, so I've read our bill and I read the California bill last night as well. And I guess an ongoing question for me in both bills is there is some reference to the in-person visit being the gold standard, or what you're comparing to for the purposes of defining parity. The California bill even calls out that for where there is no equivalent in-person visit, that I guess the field's wide open and a group can decide to reimburse that as they see fit. So I guess the question is, what is that? What is the thing in telehealth for which there is no in-person equivalent? I guess in my mind, that is some of these store and forward visits, because they are very different than an in-person visit. But I guess you could have a broad interpretation as well and say any telehealth, if you're providing some kind of assessment and diagnosis, there is always an in-person equivalent. So I'm not clear, I suppose, what our intent is when we talk about these possible exceptions. What are examples of those?
And I'm racking my brain to think of what would be something we could do by telemedicine that you couldn't do in person. The obvious one would be store and forward.
That occurs to me, but I don't think that's what are we all thinking the same way, I guess, is my question.
Just thinking about an in-person visit, when you use data that you've already accumulated, you could still incorporate the data you accumulated from store and forward information in an in-person visit, correct?
Sure.
That's right.
So I still don't see how store and forward technology used is exclusive from in-person visit encounter.
Well, according to the nurse practitioner that I visited this summer with a little skin thing, and and I could have actually taken a picture of that and not have that in-person visit and been able to send that or have like a teleconference and send that, and have a discussion about that. And then she in turn can send that, or I could to the dermatologist for follow-up. That's how I see it more in dermatology than other areas. And I'm non-clinical, but that's how I would look at it.
Yeah.
And this is Cody. I wonder if part of the challenge becomes where does this stop? So there are more and more chat with a provider services that aren't even a video or telephone visit.
Right.
And so is that considered telehealth? Is that a store and forward? We get into a tricky area if we're going to start requiring parity for those encounters as well. So there's a lot of gray areas in all of this.
Yeah, and I guess that's where I do raise some concern around the parity term. How far does that go? And this is the slide from California. It's the final sentence here, where I guess it recognizes there are cases where there are telehealth services where there is not an equivalent in-person visit. As I look at our law, I don't see that defined. And as we're increasingly including store and forward, I do wonder, do we mean chat? Do we mean an e-visit, which is a fairly simple store and forward questionnaire kind of thing? I wasn't sure what we had in mind, and I guess for me it may rest on what the word equivalent means. You can have certainly, again, diagnosis and treatment rendered through a chat, but is it equivalent to an in-person visit? Personally, I think it's probably not, but I don't know exactly what we intend.
So Chris and Cody, it sounds like you have a problem with the California language here about when negotiating a rate of reimbursement for telehealth services for which no reimbursement equivalent exists. It feels like there's creep that things like store and forward should be cheaper. And I think, CMS does have a different pay structure for some of the store and forward, things like that. So maybe we just try to mirror more what CMS is doing. I think Josh wanted to chime in here, and then I'd like to acknowledge Sean from WISMA as well. So maybe Josh, do you want to chime in, and then Sean?
Well, I just hear the questions, and I'm wondering if anybody knows what the general goal of that statement was. It's hard to interpret exactly what it means, but does anybody know what the spirit of that language was supposed to address?
The sense that I got from the research that I did, this is Nicole, is because telehealth is changing so rapidly and the technology is advancing quickly, I interpreted it as sort of keeping an open end for any changes that will happen in the future. So instead of having really narrow language that talks about the technology that is available now, I thought this was sort of, something that's a bit more forward.
So not stifling innovation.
Yeah.
But I would agree with what Chris and Cody are saying, is that, a store and forward visit, if they're faster, and they are reimbursed differently from when you look at Medicare, and I would agree with your point that they probably should be considered different and paid at a different rate. That's my own opinion. But Josh, did you have an opportunity to ask all your questions?
No, that makes sense, that it's just a way to allow the conversation to continue. Getting too specific about it probably then wouldn't be fruitful, sounds like.
Okay. Sean, do you want to chime in?
Yeah, thanks, Dr. Scott. Sean Graham, Director of Government Affairs of Washington State Medical Association. A couple of things to note on this issue. So Dr. Scott used the term narrow networks a number of times. I want to flag that, as it's typically referred to, at least in legislative circles here, narrow networks are allowed under Washington state law. And it's generally construed to mean that it provides the networks that aren't as broad as what is, typically been utilized in the past. That's something that is allowed, and that's something that the Office of the Insurance Commissioner is, fairly supportive of in the interest of trying to hold down premiums. Specific to the notion of substituting telehealth services for in-person services for the purpose of demonstrating network adequacy, the California bill also specifically addresses this. I think it's the next provision to what we have. And it says this section does not alter the obligation of a healthcare service plan to ensure that enrollees have access to all covered services through an adequate network of contracted providers. So effectively saying that, you can't substitute telemedicine for in-person services for the purpose of network adequacy. And important to note on that piece, we have had some discussions with Representative Cody of late. She has indicated an interest in at least pursuing the idea of allowing the substitution of telemedicine services for in-person providers to constitute network adequacy, and maybe in some limited capacity, such as for psychiatry services. But that is something that's going to be considered that would run directly counter to the California law.
Okay. So we might be kind of painting ourselves in the corner if we adopt the neural network language, is what you're saying?
I think the narrow network language, this provision in the California law would prohibit the allowance of what Representative Cody wants to explore in the way of substituting telehealth services for in-person services. And that's, from the Medical Association standpoint, we've indicated that that's something, obviously we would entertain conversation on that. We do have an existing concern with narrow networks and would be concerned with further narrowing them or shifting more care, just having networks that don't have access to in-person providers for certain services would be something that would be of concern. Yeah.
I'd like to call on some of the other folks like Chad or Stephanie or Kathleen, because I know you guys have had some preliminary experience, especially denial of claims that you felt like legitimate.
Yeah, absolutely. It's Stephanie here. We have had some issues. We have a child psychiatrist that sees patients remotely 100% of the time. And there are a handful of plans that offer their telehealth services only through national vendors. And most of them, interestingly, are through Teledoc. And so when he submits bills, because their telehealth service can only go through Teledoc, even though they don't have a child psychiatrist that can see this kid, they can't get it paid because he only sees his patients via telehealth, virtually via video visits at this time. And so I think as we see more and more of this, the national vendors having contracts with the actual payers, we're seeing more and more issues. And this was widely discussed at the conference that was up in Alaska, that it was an issue. And so they were sharing how in California is one of the states to just push forward to say, hey, like, that's fine, you can have Teledoc be your vendor, but you also have to pay the health systems if they're seeing patients virtually as well. And so we've had some denials, and we think they're really quite unfortunate.
Senator Becker had a question.
No, I don't have a question, I have a comment. This is something that is, a denial for this reason is really disturbing to me. And, Teledoc has been around, but I have a mental health bill out there that is going to get telepsychiatry and telehealth visits into the kids in the schools, and we're trying to develop one of the best systems in the nation. And if this is an issue, brought up as a denial, this will absolutely curtail any help to these kids that need the help in the schools. So this is very bothersome to me, and I'm venting because I've not heard this, and this is very disturbing.
Yeah, we tend to agree. Our families really highly like being able to do the visits via video because it keeps the kids in school, less time off of work. It's better for the families. It's better for the kids. They get to keep their same provider and the continuity for these kids who really need this care, this mental health, the psychiatry care that they're getting is super important. And for the payers to say that they won't pay because their telehealth contract is with a Teledoc or a Doctors on Demand, it's been unfortunate, and it really is harming such a vulnerable population. And this is the most that we see. The virtual urgent care folks, they're happy to drop $25 on the visits with us and don't complain much. It's frustrating just the same, but the child psychiatry one is the one that really put us down this path where we're like, we should really look at this.
Thank
So
you.
glad this was brought up.
Yeah, thank you, Stephanie. Chad, I know you have some experience at Virginia Mason. Do you want to share your experience?
Yeah, so first off, I kind of want to put a disclaimer. Our contracts have recently changed with one of the larger insurers, but what we were finding is that there were certain plans that were really, I think that they've been attractive plans for maybe some folks, but those plans kind of limited telehealth to certain companies like Teladoc and so forth. And so, obviously, when you're contracting with your payers, everything matters in that language. But originally, we were getting denials as well because some of the plans were actually referring their members to a Teladoc scenario to seek out care first. So, certainly I can see, obviously, with the large mergers that are happening, that there's a risk for this kind of scenario happening more frequently in the future. So I think it's definitely something we need to watch out for very carefully.
Chad.
Yeah, and that's, I would say, one of the arguments for from a carrier, a multi-pronged approach, understanding that users will have services, there's a lot of local providers that are starting to do their own telehealth, bring on platforms that sort of white label to their solutions. And so it's not only isolating to a single vendor for all telehealth services, but also enabling your network to deliver those services via policy as well. And so, I don't quite know the full landscape of what other payers are doing from that perspective, but I know, at Regents, we do have that policy in place to allow, again, our network providers to deliver those services. And in trying to address those situations where appropriate services are being delivered to members, but keeping it from being sort of that proprietary feel,
So a question I have for you as representing Regents is, does Regents, like with PBMs, have an ownership in the telehealth services, those companies?
I can't speak to if you're asking ownership as far as investment. I can't speak to that. I'm not aware.
I'll find out. Thank you.
Sure.
Yeah, and to answer that question, there is an insurance company that does have an investment in Teladoc. No one on this call, but yeah, so I think there's a conflict of interest there as well. Kathleen, anything you wanted to say from Swedish Providence perspective on this?
Thank you for calling me out, Dr. Scott. We have been experiencing the same as Chad. I was going to put an exclamation point and say we've been experiencing the same things with our contracting recently from the PSJH, or the Providence St. Joseph Health Telehealth. Chad called out specifically Teladoc, and that is our vendor is InTouch Health, and so it'll be interesting to see with the recent merger what those implications are going to be on a lot of our contracts coming up.
So Kathleen, I think that's a really big point as well. So we also have kind of designed our platform and architecture around InTouch Health, and with the recent merger with Teladoc and InTouch, we're kind of nervously awaiting to see what's going to happen with that. So not only have they aligned with, I think, more than one insurance company or payer, they're also going to have a lot of control over one of the largest telehealth platforms in the nation, I think.
Right, there's like 50,000 docs, I think.
Yep, exactly. And they already had a pretty large group of providers to begin with, but
right.
This changes the dynamic entirely.
Yeah, we have had conversations. I understand our leadership has had conversations with InTouch, actually I think on Sunday morning last week, very early, with regard to the impact of this, and were reassured at the time of support, etc. Our contracts are up at the end of this calendar year, So I think we too will be looking very closely at the implications of this.
Yeah, I would just say UW's a third entity that's in the same situation. We do contract with InTouch as our platform, and with Teladoc now acquiring them, it really blurs a lot of lines. It's super complicated, but the initial indications are that we are getting claims denied for we feel like are legitimate services, continuity of services, and for which Teladoc does not have the expertise on their staff. So.
Right, and I don't know, is Lisa Roach on today from PSJH? I think we have a billing conversation. Lisa Roach is works with our billing department with Providence, and we are quite aggressively looking at conversations with different insurers and what's being denied and not, as I'm sure we all are. There is quite a bit of concern about the rationale behind the denials, so we will be continuing to address those.
If I may ask a question of you, this is Senator Becker. Did you receive notification of a change of an existing contract, or are they only doing this upon your new contract? And if so, how did they justify the denials of a contract that didn't include this language?
Are you referencing the different commercial payers?
I'm on anybody that's paying you. So for example, if you provided the service in November and you were under one contract and your new contract will be coming up effective, January 1st or whenever it is, was that provision in the previous contract, or did they just start paying as if it would be the new contract?
It was provisioned in the previous, so any of the changes that have happened have sort of morphed without any discussion.
Thank you.
Well, so maybe, are there any other comments? Because I kind of want to wrap this up. We have a couple other things I'd like to get to, but one last comment or question. So maybe if I can summarize, I think that there was concern about the stipulation about any non-equivalent, I think, and that's in the California bill. And then maybe understanding some of the complexities of the narrow networks, especially what Sean was saying about how using telehealth could help assure network adequacy, but there's a concern about a requirement to use telemedicine over in person. I hadn't really appreciated that. So there's a layer of complexity here that I think we need to talk about a little bit more. So what do folks feel like should be the next step to understanding the narrow network idea? Should we come back to it, Sean? Are you able to give us a little bit more of a deeper dive next time?
Glad I don't tell my head that was the next collaborative meeting.
It's in March.
Okay. So it's possible that this would still be pending in the legislature. I know that Representative Cody intends to use your bill, maybe not to be amended per se, but to be a vehicle for that broader discussion on utilization of telemedicine to constitute network access.
And I would like to have a conversation with Representative Cody, Senator Cleveland, to make them aware of this. And Sean, I would like you to be there to help me to make sure I'm not overreacting on something. But this has, I think if it's affecting the telemedicine platform and what we're doing here, we should have it come back to this collaborative for further discussion, so we're not put in this, oh my gosh, situation, and that we can address it and help Cody on what she wants if it works.
Yeah. I don't, for my part, I don't think the title of your bill is broad enough to allow this to be incorporated directly, but this is something that, certainly merits further attention from this group.
I'll just read one last comment from Chad, that as the rigor around insurance plans decrease, the incentive to contract with Teladoc and others in narrow networks for payers to maintain low-cost plans increases. and that just leads to disparity in care continuums. So appreciate that. Okay, well, thanks everyone for just making us aware of this issue, understand the complexities of it. Next, I would like to move on to an issue that came up when my colleague, Dr. Ryan Kimmel, was asked to testify about progress on the psychiatric consulting line, or PCL. So as some of you may recall, there were a lot of bills that passed last legislative session that were trying to address some of the gaps in mental health care. One of them was establishment of a phone line called the PCL, where providers, PCPs, could call in and get advice on actual patients. And that bill stipulated that in the future that the doctors who are answering the PCL would see patients by televideo, to actually start to see them and to give advice. What Dr. Kimmel had testified about is that if a patient is calling from a hospital or calling from a clinic, typically that doctor would need to be credentialed in that facility. So from a patient perspective, anyone who is beaming in, they think that doctor is a representative of that hospital or that clinic, and without being credentialed, they're not. There's all kinds of risks, malpractice and things like that. Credentialing is when a hospital checks that you actually went to the medical school you went to, that you actually passed your exams, that you don't have a bunch of judgments against you, basically doing all that checking. It takes about 3 months to do that. The way that we have gotten around it at the University of Washington is something called proxy credentialing. So what it does, I have something called the Office of Medical Staff Administration. And they're the ones who are responsible for keeping track of my medical school, my residency, any kind of legal issues. And then they would just forward it to that hospital. So it's a much faster turnaround rather than them having to do it. It takes about a day or two. And I think that what Representative Schmick had asked us to consider, is there a need to require proxy credentialing? I think that this is something I'd like to study a little bit more in depth at the future collaboratives. But it just was more of a kind of a flagging of this issue, and for other, especially other health systems, how you come up with solutions, and I would ask you to consider whether this needs to be written in legislative language to address. Senator Becker, is there anything that?
Do you have a bill number that?
No, there is no bill.
Oh, there is no bill. This is just, is it through the medical commission that this was established, that you have to be credentialed?
Yeah, this is
more like a consultation than a?
The envision is it would be a consultation, and it kind of triggers then that you need to be privileged and credentialed in that facility. And I don't know if this is a UW only kind of thing. That's why I'm throwing it out there, and it's unique to the PCL, or if there's broader implications for other health systems.
And I would have a lot more questions I'd like to ask you offline, and because I used to do the credentialing, and then we could do that temporary credential for like a surgery in another hospital, but let's have a further discussion.
Okay, and I think that we'd like to have Cartel and potentially Dr. Unitzer or Dr. Kimmel come to give us a little bit more color to that. I just wanted to flag that as something that's come up, and hopefully we can take a deeper dive in future collaborative meetings. So the next thing on our agenda item is more housekeeping. So Nicole would love to get some hosts for our upcoming meetings, and we've pretty much set out the meeting schedule. And so I think we're in need of a host for March 24th, May 12th, and July 14th. And so if anyone feels like they can host us now, please raise a hand. Nicole and I have figured out a really good mobile solution. So as long as you have pretty good internet, we're kind of like a little moving, technology suite here. So,
We're easy guests.
yeah, easy guests, quiet room, and good internet is all we require. So if you wouldn't mind signing up.
It's Steph. We could host March 24th.
Oh, great. Thank you, Steph. Yeah, you guys have hosted before, and it's worked out really great, so I appreciate you doing that again.
Can I reach out to you directly, Steph, or should I contact someone else?
Yeah, I'll email you and just CC Kim, who will get us to the room.
Oh, perfect. Thank you.
Yeah, I'll send that later today.
Nicole, this is Kathleen with Providence. If you want to pencil me in for the 12th and follow up with me, I'll verify a site in Renton.
Oh, beautiful. Thank you, Kathleen.
Yeah.
Okay, at least we have the next two. Anyone, any takers for the summer, July 14th?
Want to come down to Wyoming?
That would be quite a trip.
Yeah, it would.
Okay. Well, great. We'll be soliciting in the future. So we're right at about 10 till, so we wanted to open up for public comment. Anyone who's on the phone or in the room wanted to ask questions or make comments on what we've talked about today. And then please, if you could just tell me your name and where you're from.
Yeah, come forward.
Yes, yes, please.
I'm Dave Stanfield, optometric physician, and I represent the Optometric Physicians of Washington. I'm the vice president of the association, and I'm actually from Shalos. I'm here to voice my support of Senate Bill 5759. I've enjoyed the conversation that you've had, and both myself and my organization are strongly supportive of moving this bill forward. There are a couple things I want to say about it. Number one is this is not the same bill that was introduced last year. This is a totally different bill. It is not an anti-telehealth bill. This bill is intended to maintain the standard of care for patients that choose to get prescriptions, either glasses or contact lenses, online. It is intended to maintain the standard of care, to maintain continuity of care, and I appreciate your comments, Dr. Scott, on the continuity of care, and it holds the prescriber accountable. Overall, this bill seeks to replicate the experience a consumer or a patient would get by having an online service compared to what they would get if they went and had an in-person encounter with their contact lenses and glasses. We do believe that patient-provider relationship begins once a consumer or patient gets online to purchase contact lenses or glasses, and we feel the same standards should apply. There are a couple of comments I want to make from what has been previously said, particularly regarding contact lenses. Contact lenses are a different entity. They're wonderful. I know many people sitting at the table wear contact lenses or have worn them. There are some things you have to watch out for. And I would say currently, at this point, I'm in a clinical setting where I work with ophthalmologists, and I've been in practice for 39 years. I do not prescribe contact lenses or glasses, so I have no financial stake with this bill being passed. But I do see contact lens problems when they come in the form of corneal ulcers and infections.
Can you speak up? I'm sorry. I just want to make sure
Maybe,
Yeah.
Great.
Very nice.
So I'll repeat. I just want to speak regarding contact lenses, and they're wonderful, but there are some things you have to watch out for as a provider, and I've seen a number of contact lens infections and contact lens complications in my 39 years of experience. My concern is that if you let a patient go 4 years between exams, which can be the implication with the renewal process, that you'll miss a lot of problems. And there have been studies done. I think you've all been given a lot of information from our state association regarding yesterday or the day before regarding some of these studies, so you may refer to that. But there is a study that shows that
people that get their contact lenses online or by mail order have a higher rate of corneal infections. And from a lay perspective, corneal infections can result in significant loss of vision. So it's always a big concern. As a provider, when you see a patient with a contact lens, there are things you have to look for. You have to look at the periphery of the cornea to look for signs of corneal hypoxia. If the contact lens is fitting too tight, you'll see blood vessels coming in the periphery of the cornea, so you want to look for that. You want to look for deposits on the surface of the contact lens. You want to take the contact lens off, you want to look at the surface of the cornea to make sure there's no irritation, there's no potential places where you can get a microorganism embedded in the cornea. So these are all important things that raise our concern with having online contact lens refills, because another study that you have been provided shows that patients that have online services where they fill their contact lenses do not follow, have poorer practices regarding contact lens hygiene and practices. So our concern is that if patients go too far between refills of their contact lenses and they do not see a provider, you're going to get an increased risk of corneal infections and other problems. So this legislation does not really, is not anti-telehealth. Basically, this legislation is just holding the prescriber, the online prescriber, to the same standard of care that someone in person would be held, so that that prescriber has to check the records, make sure that the appropriate examination and the appropriate intervals have been done, and with the initial prescription, when that is written, that prescriber needs to get records from the examiner, who may be different, and make sure that the appropriate examination has been done, and that the prescriber also takes a careful case history to make sure that if the patient is appropriate for an online prescription, whether it's glasses or contact lenses.
So Doctor, I just want to
Yes.
stop you for just a second,
Sure.
because the collaborative's role is to look at, from what we did, is look at the 1-800 information, look at the information from the other, from your perspective, and not support necessarily one bill right now, but to look at this whole process, and we have a methodology by which we vote before we will support a bill or even present a bill. So I understand what you're speaking about, and I appreciate you coming, and I think that
We have time, we have 30 minutes for you to present to the next room.
at the next meeting, so I think that would be a better use of your time. We can get into more detail and ask you more questions.
I appreciate that, Senator Becker. So,
I appreciate you coming.
Thank you
And
very
look
much.
forward to the discussion, and also Dr. Ranko.
Thank you.
Thank you.
Yeah, appreciate it. Thank you. Any other questions or comments from the public? Okay, well, very good. Thank you everyone for coming, for participating. Our next session will be March 24th, and Stephanie will be speaking at multi-care, but I think many of you have been there before. We'll confirm on the location, and welcome any other comments or questions in the meantime. We'll be posting a lot of these materials to the website. So thanks everyone, and have a good day.
Thank you.
Thank you.